Good afternoon, doctors. Welcome
Good
to you on this experience sharing program on managing PPH with case studies from labor room and experience with Carbetocin. This initiative is from Heathrow Healthcare, and Heathrow Healthcare, as you all know, has got 25 years of excellence with 36 state-of-the-art manufacturing facilities, 300 plus products in portfolio, and presence in 126 plus countries. We have 21,000 employees globally, and we are amongst the largest manufacturers of ARV, APIs, and FDFs in the world. And we have Asia's largest API manufacturing facility at Visakhapatnam, Andhra Pradesh. Vitro Healthcare is a 360 degrees solution provider striving to fulfill unmet healthcare needs, reaching to customers across India with wide range of products encompassing multiple specialties, pioneering in quality and innovation, and we have distinction of bringing 4 biosimilar products to market within 5 years of initiation. Today, we have got Dr. Meenu Mittal with us to share her experience on Carbetocin. We all know that although there are many paper and documents on use of Carbetocin in PPH, our own doctor's experience always matters and it always gives us more confidence on use of Carbetocin. Dr. Meenu Mittal, just to introduce her briefly, Madam is MBBS and MD from JNMC Aligarh, worked as lecturer for 5 years at CMC Vellore and working as consultant in own Asian hospital for last 14 years, with special interest in gynecology, oncology. Over to you, madam, for this session.
Thank you, sir. Thanks a lot. Thanks, first of all, thanks for the Hetero Healthcare for inviting me and giving me this opportunity to just let me share my own experiences in front of you. As we all know, PPH is a nightmare for all of us anytime, whenever it happens. WHO says definition of PPH, we have been studying it for past many years. It's a loss of 500 ml of blood following a normal delivery and 1000 ml of blood following a cesarean section. There are many causes of PPH. Even it can occur even in the women. We don't think that they are at the risk of PPH. So in so many patients, we can't even predict we can have PPH. PPH is the leading cause of maternal mortality in low-income countries and majority of the cause and major cause of death of maternal deaths. So we have globally many cases of PPH. It's the major cause of maternal mortality, accounting for about 35% of maternal deaths. The maternal mortality rate in developing countries is quite high as compared to in the developed countries. Many millions, 14 million of women, they suffer from PPH. Following a cesarean section, the incidence of PPH is slightly higher as compared to normal delivery. 38% of maternal deaths are due to PPH. 25% of them are in India and 2/3 are due to PPH. India has a very high maternal mortality rate of 540 per 1 lakh live births. Now as we all know, the causes of postpartum hemorrhage, we have 4 T's: tone, thrombin, tissue, and trauma. Tone, we have the uterine anomaly. It's majority in more than 2/3 of the cases. The problem is with the tone of the uterus. The uterus is not able to contract, which leads to bleeding. Then we have coagulopathies like trauma, failure to clotting. Then we have trauma, in which we can have vaginal or cervical lacerations or rupture of the uterus or uterine inversion. Then in tissue, we can have retained placenta, retained placental bits, and abnormal placenta. We all judge clinically what's the grade of PPH according to the shock, according to different parameters we have. Now we can detect it whether it's a mild, moderate, or a severe degree of shock, depending upon the amount of blood loss, the changes in the vitals of the patient, and the symptoms and signs which the patient is presenting it slowly. We have abdominal tenderness, circulatory collapse, the increase in the abdominal girth, loss of uterine contractions, maternal tachycardia, and vaginal bleeding. Now, how do we diagnose a postpartum hemorrhage? we need to evaluate the patient. It has to be very quick and correct measurement, a rapid assessment of the patient's status. We need to see her vitals, whether the patient is having tachycardia with hypertension, what's the amount of blood loss. Then we can examine the patient, assessment of the entire genital tract. We need to rule out whether it's a trauma, or the tissue. We need to make the diagnosis for what is causing PPH. We need to assess all genital tract for any lacerations, injuries, any the cervical laceration. We need to see whether it's a uterine rupture or not. We need to examine whether there is a retained placenta or placental tissue. We should have an ultrasound so that we can check whether the uterus is empty or not. Then we need to examine the fundus of the uterus to check whether it's uterine inversion or not. Then we can have a lab assessment to know the complete blood picture of the count for hemoglobin, for platelets, and we can have the coagulopathy to need the coagulation profile of the patient. How do we approach to a patient of a postpartum hemorrhage? First of all, we need to make a diagnosis, like what is the cause. We need to see what is by examining the patient, by vitals, by doing a blood test. We can know which type of PPH we are dealing with it. Then we need to call for help. We need to may manage her ABC, airway, breathing, and circulation, put her 2 wide bore cannulas, and then we can start with the oxytocins. We can start with the uterotonic agents like oxytocin. We can even give ergot alkaloids if they are not contraindicated, and we can give prostaglandins if the patient is not asthmatic. Then with this, if the patient is bleeding is not controlled, we go on to the second step with the bimanual compression, and then we can have a balloon tamponade. Even if these methods, if the bleeding is not controlled, then we go on to the surgical methods like we can put Belen sutures, or we can do the stepwise devascularization, like doing a uterine artery embolization, uterine artery ligation, ovarian artery ligation, and then we can go for an internal iliac ligation. Now, initially, we like long back, we were having availability of only mainly the oxytocin and ergot alkaloids for the control of bleeding to the patient. Then slowly misoprostol came in, and now we have a new formulation, carbetocin, which is a synthetic oxytocin analog, which we can use to prevent PPH. Carbetocin is a synthetic analog, and it's of the same family as the oxytocin, but it's heat stable, wherein we need oxytocin to be preserved at about 2 to 8 degrees of Celsius. But for carbetocin, it's the heat stable formulations. We can easily store it at room temperature. The half-life, the shelf life is quite good, and it doesn't need any cold chain. Now, we have different uterotonic agents which can be used to prevent PPH. We have oxytocin, we have carbetocin, we have ergometrin, symptometrin, and misoprostol. These can be given either at the time of crowning, or at the delivery of anterior shoulder of the baby, or even at the end of second stage of labor, or following delivery of PPH. Prophylactically, we can use them to prevent PPH, or otherwise we can use them whenever the patient develops PPH. As I've already told you, carbetocin, it's a synthetic analog of oxytocin. It was created by causing several modifications to the structure of oxytocin to get a better half-life, a good more half-life of this, and less degradation of carbetocin. Carbetocin is mainly used for the prevention of PPH due to uterine atony. We have got a 1 vial of carbetocin containing 100 microgram of it in 1 ml of injection. Now, this table, it just shows comparison of oxytocin with carbetocin. They have told like oxytocin is a naturally occurring hormone. We get it from the posterior pituitary. Carbetocin, it's a long-acting synthetic analog of oxytocin. Both, they bind to the oxytocin receptors which are seen in the uterine myometrium, causing contractions of the uterine myometrium and decreasing the bleeding by increasing the tone of the uterus. But the difference is the time for which the carbetocin binds to the uterine myometrium is more as compared to the oxytocin. Both can be given IV and IM, but the half-life of, there's a lot of difference in the half-life of oxytocin and carbetocin. Oxytocin has a very short half-life of 1 to 6 minutes, whereas the carbetocin has a longer half-life of 40 minutes. So, if the patient is bleeding, we need a continuous infusion of oxytocin. But the carbetocin, a single dose is effective. For storage and transport for oxytocin, we need a lesser temperature. We need to store it at 2 to 8 degrees Celsius. But carbetocin, the heat stable one, we can store it at room temperature. We can't use carbetocin for induction and augmentation of labor, but it can be used for the prevention of PPH. While oxytocin can be used for everything. We can use for induction, for augmentation, for prevention and treatment. We had a WHO champion trial, which was done to compare. It was a very large clinical trial, was done in the prevention of PPH. It was a double-blind study. The main objective was to compare the effectiveness and safety of carbetocin, the heat-stable carbetocin, to oxytocin in the prevention of PPH after vaginal birth. Around 30,000 women were enrolled across the world, including India also. The primary outcome was the proportion of women with a blood loss of at least less 500 ml or the use of additional uterotonic agents, and the proportion of women with a blood loss of at least 1000 ml. Then after comparing both of them, they found in the patients with a blood loss of more than 500 ml or the use of additional uterotonic agents, the efficacy was nearly the same. But in blood loss of more than 1000 ml, the RR ratio was slightly 1.04 in cases of carbetocin. Adverse effects in nearly was same in both the two. So the frequency of blood loss of at least 500 ml or the use of additional uterotonic agent with carbetocin was compared to be non-inferior versus oxytocin. The use of additional uterotonic agent interventions to stop bleeding and adverse effect did not differ significantly between the two groups. So they finally concluded that carbetocin was non-inferior to oxytocin for the prevention of blood loss of at least 500 ml or the use of any additional uterotonic agent. There was a Cochrane review. It came for the prevention of postpartum hemorrhage. It was data from 11 studies involving more than 2,500 women. The author had concluded that the women who underwent cesarean section, carbetocin resulted in significant reduction in the need for other uterotonic agents compared to oxytocin. Also, carbetocin is associated with the less blood loss as compared to symptometrin for the prevention of PPH who have vaginal deliveries with lesser side effects. We have different recommending bodies who recommend either we need to use oxytocin or carbetocin or misoprostol or ergometrin for the control of PPH, for the PPH prophylaxis. So we have WHO. It still says the first line drug is oxytocin, but we have second line as carbetocin, then misoprostol, then ergometrin. But the Society of Obstetrics and Gynecology of Canada, it says carbetocin as a first line drug. Then we have New Zealand Society. It says prophylactic uterotonics. FIGO says carbetocin. Germany, Austria, and Swiss body, they all, and the France, they all say that we need to use carbetocin as the first line drug for PPH prophylaxis. Now we'll have a few panel questions.
Yeah, madam. Madam, how is your experience on use of carbetocin? Although there are studies and documenting efficacy, what is your experience on use of carbetocin?
Sir, I've been using carbetocin for nearly a year now, and I
Hmm.
use in every patient of mine except for those who I do an elective cesarean section.
Okay.
But in normal delivery, I have seen like the even the bleeding from the separation of placenta is quite less.
Hmm.
Placenta separates early, and only in two patients I got this. Like my patients, they had bleeding, but not to the extent of too much of bleeding.
Okay.
It was controlled easily with massage and oxytocin.
You generally use IV route or IM route?
I give IV
IV route. As a bolus injection, so drip,
as a
slow drip.
bolus injection, slow,
Bolus.
diluted in 3 to 4 ml of
Diluted.
normal saline over
Correct. Correct.
half to 1 minute.
Correct. Now, just few of these questions, madam. What is the patient profile where the doctors can anticipate PPH? Although PPH can happen anywhere, anytime, but
The
generally
PPH,
speaking, where we
PPH
have,
can happen even in the low risk patients where we don't even
yeah,
think of that this
exactly.
patient can have PPH. But in those
Expect the unexpected,
patients,
sir.
we have an overdistended uterus like twin baby, or we have a big baby, or those who have a prolonged labor or preeclampsia. In those, we can anticipate PPH and we should give prophylactically, we should give carbetocin.
Even fibroids where uterus may not be able to
Uterus with
contract properly.
fibroids,
Yes,
where we think that
yes.
there might be some difficulty in the contraction of the uterine myometrium.
Diabetes can also, or the hypertension can also make the patient prone for PPH.
Yes.
Next is, in which patients would you prefer to use carbetocin or prevention of PPH?
Sir, those patients who are definitely at risk, like those with anemia
High risk.
also,
Oh,
in those,
yes.
I'll definitely use carbetocin over oxytocin in all those
Yeah, because
patients.
even little blood loss can also be a significant thing in anemic
Can be
patients.
detrimental to the patient.
Yes, yes, yes. Can you use your experience, madam, in patients with retained placenta after, of course, after removal of placenta?
I have never used, sir. After I've never given, like I have seen in 2 or 3 cases, if you give after delivery of the placenta, the effect is little bit less only.
Less, okay, as compared to, because
So
which is why it is
as
recommended for
compared to when we
prophylaxis.
give the after delivery of anterior shoulder, or even after the birth, but
Shoulder,
before the delivery of placenta, if we are giving carbetocin,
placenta,
the effect is better as compared to giving after delivery of placenta. So I've never used
placenta.
in
So
retained
what do
placenta.
generally in cases of patients with retained placenta, what is your preferred drug?
I give sir oxytocin only.
Oxytocin or
Yes,
textbook brand? Yes.
yes,
Can you use carbetocin in any experience, madam, your experience in RH negative mothers?
yes, sir. We can give,
Okay. RH negative mothers could be a problem, especially in interiors where there are low, I mean, the facilities may not be so great and
because
bleeding
this
could be dangerous.
if this bleeding happens, there can more be a
Yes.
fetal-maternal
Absolutely, absolutely,
transfusion.
absolutely.
So it's
Yes.
better to give in carbetocin.
Carbetocin. Can a doctor use carbetocin for prevention of PPH if oxytocin is used for induction of labor?
Yes, definitely.
So most of them would be using oxytocin for induction, for
Yeah,
dilatation of,
yes,
yeah,
yes. Because it's carbetocin is contraindicated in that purpose. So when we
correct.
use definitely we are
Oxytocin.
using oxytocin for induction of labor. Once
Correct,
the
correct,
patient is
correct, correct,
delivering, we give carbetocin.
correct. I mean, you have been generally using IV, but is there a place scope for IM route, you feel? Because IM has got a slightly longer duration of action as compared to IV.
Hmm. Suppose so in a few cases I had like patient has just come in and she
Okay.
delivered. So no IV
Oh.
line. So you just give an IM carbetocin.
A practical approach. Yeah.
Yes,
I suppose one of the greatest advantage of Carbetocin is it can be used intramuscularly or that may not be drip required, which is important in an interior setting in our country.
definitely,
Apart
sir.
from,
Because
yes, yes,
WHO also says you don't need an IV drip. You need to,
exactly,
because you
exactly.
need to ambulate the patient.
Yeah.
So
And
she does.
yeah, and we do not have facilities in this area. We do not have help. Many times doctors do not have any help. At that time, these routes could be of help. And again, storage facility, we do not need refrigerator. It's a big thing in our country.
Definitely, sir.
If the patient is not responding adequately with carbetocin, what additional neurotonics do you use? Of course, all is the answer, but then in your sequence of preference,
Like, I'll start with oxytocin and I'll put
oxytocin.
misoprostol. If the placenta
Okay,
is out, then according to the BP, if BP is normal, then we'll give ergot also,
methargine.
ergot alkaloids. Yes,
Okay,
methergine also.
okay. And specific advantage of carbetocin over other vitamins? Yes, of course.
So
I mean,
first,
apart
a
from that
single
cold chain, and
one dose is enough.
yes,
And then we
enough.
have a
Good
longer
length of
time, like effect is there for at least 1 to 1.5
long.
hours. By the time
It's a
uterus
big thing.
itself, its stone comes up, the
Yeah,
mother starts feeding the baby, she'll have
correct.
something. So then other factors also come into play, and then the uterine tone becomes good.
Should carbetocin be kept as a reserve drug or should we use a first line? I mean, there's no point in keeping such a drug for as a
I
reserve drug.
feel, sir,
I
it should
suppose
be
that.
used as a first line drug. There
Correct.
is
Because
no
the life is at
point in
stake. Yes.
waiting for the patient
Hey,
to have
yeah.
bleeding and then you start doing some action.
And then suppose if it doesn't work, we don't know what will happen.
Yeah, that's the
Then
problem. If
yes,
it doesn't work,
yeah,
then we are left with
uh,
old drugs only.
yeah.
And then
Correct.
sometimes patient don't respond to oxytocin at all.
Yes. And once that resistance starts, that is difficult. Then we finally land in
Like
OT.
sometimes I feel like all the receptors, they have been blocked by the drug what you give,
Yeah.
and then the drug
Correct.
is not acting at all. So
Then
it's
it is
better.
difficult. Yeah. Pointless keeping a reserve drug. What is the role of an anesthetist, madam, vis-a-vis gynecologist for choosing a drug for prevention of PPH, for especially bleeding when it occurs?
um Sir, anyway, when we are doing a Caesar, once the baby is out, they give oxytocin and they give
Hmm.
methergine. But then afterwards, if the patient is bleeding, we only tell them, please do this, and do this, and give this now.
Correct. They may not have experience about carbetocin per se, like
Yes,
gynecologist.
yes. I tell them like you give carbetocin in this patient
Correct.
because they don't
And giving
anyway they
inter,
don't know the history. They come and just they are giving
correct.
spinal, so it's better to
Yes.
tell them.
And giving IV for them is their own word. I mean, it's simple for an anesthetist to give IV injection.
Yes, sir.
To conclude, take home message for the audience. What is your overall experience and on using carbetocin and a take home message for the audience?
Um, Sir, instead of having that feel when you get that PPH in your patient, it's
Hmm.
better you prevent it beforehand. So
Correct.
my own experience with carbetocin is very good. Now I'm
Hmm.
using in each and every of my patient because
Hmm.
in between I started using oxytocin in those I didn't expected any bleeding. But then there was a PPH in very severe PPH in one of my patients. So then I've stopped
Correct.
using oxytocin. I just use it for induction or augmentation. And then finally, once the baby is delivered, I give carbetocin only. That night also, I make it a point that definitely I had to give carbetocin only.
Correct. So your oral experience has been good. Any major adverse effect you have seen with carbetocin?
No, sir, no patient has ever
No.
complained of even headache or
Of any
dizziness. What are
adverse?
the minor side effects with oxytocin or
Yeah.
carbetocin? They've never complained.
Sometimes oxytocin gives that ADH type of side effects, no? ADH related side effects.
When we give excess of oxytocin, because in PPH we
Yes.
are giving so many ampules in a fluid and we are giving
Yeah,
too many fluids,
correct.
the patient gets that symptoms.
Symptoms. But carbetocin is not seen. That's
Carbetocin
important.
is very safe.
Being a symptom. Right. Thank you so much, madam. Thanks for your inputs and insights. Thank you. I'm sure our audience must have benefited out of it. And thanks all the hetero team, the marketing team, the IT team, the sales team for coordinating, conceptualizing, and IT support. Thanks all of you, and you can sign off, madam. Thank you so much.
Thank you, sir.
Thank you. Thanks, Shashidhar. Thanks, Bivas. We can sign off, Shashidhar? Yeah, you can, madam, sign.
Okay, thank you, sir.
Thank you.
Madam, thank you so
Thanks,
much once
Bivas.
again for taking accepting our
Thank you, Bivas.